edition of Let's Talk About It. This is Susan Johnson, and my co-host, Dennis O'Brien, is out doing great things this afternoon and will not be able to join us. But we have an absolutely fabulous guest, someone who's going to help us with Breast Cancer Awareness Month, Dr. Stephen Hauser. He is a doctor of radiology, and he works at Hartford Radiation and Oncology Associates at 80 Seymour Street in Hartford. And we're so thrilled that he's able to be here and talk to us about all the things we need to understand about breast cancer, how to avoid breast cancer, how to make sure that you go for your mammograms on a regular basis. So without further ado, welcome to the show, Dr. Hauser. So glad you could join us.
Well, thank you very much. Very happy to be here. Yes, thank you very much.
Thank you so much. And so I think that, this is Breast Cancer Awareness Month, and we need to start off maybe with talking a little bit about some of the work that you do at Hartford Radiology, but also we probably should, once we do that, move into how people can make sure that they get the diagnosis if they need to, or that they at least get regular mammograms.
Well, certainly. So yes, I'm Dr. Hauser, Dr. Stephen Hauser. I'm one of the radiation oncologists, working as part of the Radiation Oncology Associates group, as you mentioned. We cover actually several different sites. Our main office is at Hartford Hospital, but our focus is the use of radiation treatments as part of the treatment for breast cancers, and actually for all kinds of cancers, but certainly for breast cancer as well.
Exactly, and so that is great. So the next thing I think that is really important for people to know is that it's really important for everybody to get their regular mammographies having to do with breast cancer. And there's different types of diagnostic services, starting out with a mammogram, which may or may not be able to connect people with with a proper diagnosis, because as we know now, because of the work that we've done over the years, if you have dense breast tissue, there may be other diagnostic services that you have to have the doctor and you work together to obtain.
Yes, that's certainly quite important and very true. I can start off very plainly that mammograms are exceedingly important. It's without question, it's recognized across all societies, all studies. Mammograms historically have indeed allowed breast cancers to be found at a much earlier time point in their natural history. What we refer to as the stage of the cancer, and the lower stage is what you want, and that's because it also bears out that the earliest stage of diagnosis for basically all cancers has the highest cure rate associated with it. And indeed, mammogram imaging, mammogram screening has been found to pick up cancers at earlier stages, as I mentioned, and as a result, has been shown on several studies to lead to improved overall cure rates and survival for women who undergo regular mammogram screening. So that's without question, that's important to be doing.
Excellent. And so one of the things that I'm wondering about also is sometimes they say you should have a baseline mammogram for women. So have you got a recommendation for the baseline mammograms?
That's a very important part of what we need to make sure everyone is fully aware of and what the information supports.
Yes,
I can pretty much say that it has been supported by most of the fields involved in cancer care that beginning at the age of 40 is the time women should really start to think about getting their baseline mammogram. That will matter on several factors regarding what that woman's risk of having breast cancer might be, particularly family history of breast cancer. And so it can be certainly a conversation to have with there have been some slightly different nuances from many of the different organizations as to how exactly that should proceed. But everyone does pretty much agree that at the age of 40, you should begin the process of having that conversation with your physician.
If there's a history of breast cancer in the family, it might even be an earlier age. Could that be true?
You certainly can begin that process of that conversation. You still will not find organizations recommending that as a routine, but it stands to bear. If there's a significant family history, particularly members who have been diagnosed at young ages, in fact, it's the number of individuals, first-degree relatives in particular, that would be parents, grandparents. In addition, any male members of the family have also been shown to be putting a person at much higher risk for getting a breast cancer in their lifetime. So those are the factors that a woman might start to think about getting their baseline earlier than age 40.
Well, you raise a very interesting topic in terms of breast cancer awareness, because we often think of women as being the people who have the breast cancer, but also men can have breast cancer too. And sometimes they run into some difficulty with diagnosis because the insurance industry sometimes doesn't quite get that.
Yes, unfortunately, that is the case. The incidence, of course, is what's lower for men, but it's not rare. You would not say it's a rare diagnosis. It's probably 1/100th of the rate of what the risk is for women, but because breast cancer is so common, you certainly will find in anyone's practice several men that they've treated who have had breast cancer, and that unfortunately is the case. There's no screening recommendations for that.
Yeah.
Fortunately, yes.
I'm sorry. Go ahead.
Fortunately, it's usually a diagnosis more readily made available because of just physical examination and symptoms. But yes, it can be a little bit more difficult to get some of this tests done in that case.
So as we look at the different, the frequency, once the baseline mammogram has been done, we look at the frequency subsequent to that.
So that again can be a little bit different. There's slight nuances between the different organizations. As a general rule, most physicians, the American College of Radiology in particular, would say that yearly mammograms should certainly be happening, or you should certainly be making sure you have your physician on board and that you're ready to do that at the age of 50. The organizations will differ in terms of how long that should proceed for. For example, after the age of 70 or 75, you can start to go back to what your risk factor might be. Some people would say that if there's no family history of breast cancer, you could probably maybe go to every other year, and you will find that in some of the organizations. But for the most part, the majority of the organizations would say yearly mammograms are what a person should be doing.
Certainly. And so in going on through the idea of getting your baseline mammography and also your annual checkups every year with a mammogram every year, which is recommended, at least around here, I think, in this state.
Yeah.
Go ahead.
So, that's certainly so important to continue with your regular yearly well-being, physical, just to make sure you're covering everything that needs to be, monitored for. Regarding mammography, regarding imaging, one thing that has also been very much shown is the advancement in the technology has allowed an improved detection rate for some of the more, what in the past has been a little bit more of a problematic. You mentioned dense breast tissue.
Yes. You're reading my mind.
Yes, with regular historic mammogram imaging, it's been a little bit more difficult to identify some of the smallest lesions, just because of the nature of how a dense breast tissue pattern looks. But there's been advancements regarding the technology to improve the ability to identify more subtle changes on that tissue. And I think you may have started to talk about this at the beginning. One of the first steps that has really improved this ability is understanding that you can do supportive imaging in addition to the regular mammogram, and that, I would say, most often involves ultrasound imaging. And so that now has become much more of a standard process to consider if that pattern has been identified to improve the detection rate.
Exactly, and I have to say, back before I went to the legislature, Nancy Capello was a doctor of advanced practice nursing. She actually had dense breasts and was given a free and clear mammogram back in 2003 or 4, and then subsequently, very shortly thereafter, was diagnosed with stage 4 breast cancer, because the technology and the way that we understand reviewing the mammographies in the past had kind of ignored the dense breasts. So, and when the younger women have 2/3, premenopausal women have dense breasts, and I guess it's about a quarter of postmenopausal women with dense breasts. So having the understanding and making sure the insurance industry covers the subsequent ultrasounds or MRIs, magnetic resonant imaging, making sure that they cover those subsequent types of diagnostic applications is really important.
Yes, and there's been some improvements, some strides made regarding that. There's certainly more that has to be made aware so that it can be applied across all situations. But once again, very specifically, getting back to family risk and what an individual person's risk might be, MRIs have indeed been shown to be incredibly important for that individual who has one of the identified breast cancer marker genes, either in themselves or in their family members, and that individual is very much at a higher risk, quite a bit higher risk of developing a breast cancer, and accordingly, MRI has been shown to be much more important to be doing that as a regular screening situation, and that has very much been the case if a woman already has had a diagnosis of breast cancer and now is being followed regularly. So there have been some strides made, but there still is so much more information that has to be kind of spread out. I can finally say that regarding technology, the mammogram imaging itself has improved. The technology that allows what we might refer to as a tomosynthesis technique, or a computer-assisted three-dimensional imaging process, that technology has now been applied to regular mammogram imaging, which really affords the radiologist to sort of get a layer-by-layer view of the breast tissue, which has indeed improved their ability to detect some smaller lesions if there's a dense breast pattern. So there's been advancements regarding the technology regarding this.
Thank you so much for raising the tomosynthesis, because when I was on the Insurance and Real Estate Committee, we actually voted to make sure the insurance industry pays for tomosynthesis, access. And I think a lot of the places where you can go for a mammography now actually have that type of equipment.
That really has been put forward very nicely, and most centers now do have that availability because it has shown to be so helpful.
Mm-hmm. Very good. So moving on to, once you have the diagnosis, the different stages of cancer. Could you tell us about the different stages of cancer in the breast, and from, I think it's 1 through 4? Thank you.
So the concept of staging, what I often like to state to someone is it's almost our code for ensuring that the correct treatment is being applied to the situation that we have. That's sort of the rationale behind having a staging system in the first place. The individual stages vary quite a bit from cancer to cancer type, so there's a general rule of thumb, but the specific numbers are going to be quite different. I can just quickly run through. There's typically 4 stages. A stage 1 situation is usually a very early, very, very small, caught at the right time cancer, regardless of which type, which has a very high cure rate and often just requires maybe just removal or not too much in terms of aggressive treatments beyond that. Stage 2, stage 3, stage 4 then sort of increases in the volume and the extent of the cancer found. In many cases, that might involve adjacent lymph node anatomy, which are sort of the regions cancers can drain to. And then finally, stage 4 is a situation where you have the more extensive situation found where you probably are dealing with cancers spread to other parts of the body. But even in that, there have been dramatic advances in terms of the ability to have that situation under control for much longer than we could ever even have thought 10 years ago. So really the stage is about knowing that the correct treatment is being applied for the situation at hand.
Oh, that's very interesting and very well put, because I never really put that together when you read about it, you read about the different stages, you know approximately maybe the difficulty the patient may face, but that's a nice way to understand what the stages mean and the application of the different types of treatment. So when you have the surgery, you may also have a situation where, we could explain a little bit about the different problems with why you have a cancer cell in the first place. Maybe that would help people understand a little bit more about it. You have the cell protein that doesn't have an enzyme that fights the cancer. Is that right?
So this actually is really getting to the new frontier of what we now have available, which I'll hopefully we'll get to a little bit further down the line. But understanding the molecular steps, the process of how a cancer forms in the first place, that really unlocks the most important things we need to know about this whole process. With that information, it has allowed this immunotherapy, this whole field of immunotherapy to now have become developed, which, just very, very directly is the reason why in some of the more advanced situations, like a stage 4 diagnosis, those agents in particular have had huge strides in having that cancer under control. So the molecular basis of this, that's a whole career's worth of information to try to understand. The general concepts are a normal cell functions and grows correctly because its DNA is working properly with all the genes in their normal state. A cancerous cell basically has had, in pretty much all cases, numbers of these genes mutated. What we don't know is it a process of several getting altered at once? Is it one important one getting altered, which then leads to the mutation of several genes in the DNA? But that's sort of the idea of how a cancer begins. There's a mutation in an important gene that would otherwise keep the cell growing normally. And learning that and and learning all these different, oh my goodness, there are so many different cascades and so many different protein systems that have been learned. You can generate either antibodies against the mutation or the ability to correct the alteration, which fortunately has indeed allowed cure rates to improve or control rates to improve. So that's an incredibly important part of the field of oncology that we've only scratched the surface of. And you can certainly appreciate that when you go to some of these cancer meetings, and it's just exponentially increasing how there's new agents being identified constantly as we're learning more and more about this.
This is wonderful information, and I wanted to just kind of set the stage for the different types of treatments. But right now, we're going to stop for a minute and have our sponsors pay for the show, and we will be right back after these messages with Dr. Hauser talking to us about all the kinds of things that we need to know about breast cancer, and this is Breast Cancer Awareness Month, so we'll be right back after these messages. Thank you so much. Welcome back, everyone. This is Susan Johnson, and I'm here with our very special guest this evening, our Dr. Hauser. He is a radiologist with the Hartford Radiation and Oncology Associates, and thank you so much, Dr. Hauser, for being with us. And we're talking about breast cancer. We're talking about what you can do, how you can, if you have a problem, then you can, we're going to talk about that next. But first of all, we were talking about screening, making sure that you go and get your regular mammographies every year. And also, if something is detected, we're going to talk a little bit about that now and what some of the things are that we can do to make sure that you can have a positive outcome with that type of detection. So thank you so much, Dr. Hauser, for being on the show. And we were just setting up the discussion a little bit about the different types of stages of cancer. And now we can talk a little bit more about what the treatments are for stage 1 through 4. So we could start with stage 1, which is it's all contained within that one particular area. My definition, you can correct it.
That's pretty much the case, yes. That's what a stage 1 situation would apply. And for breast cancers in general, surgery is pretty much the important step to attain a very high cure chance. In general, surgery would typically be the first step in the treatment process. Once all the imaging and testing has completed, the surgeon would then have a very good understanding of what the clinical stage is, and that's based on the results of all the tests initially. Surgery then would proceed. Now, there's been tremendous advancements in surgical techniques and understanding of what specifically should happen. What we've learned may not have to be quite so extensive. So there's been a tremendous advancement in understanding those concepts. One thing surgery then gives us is sort of what we call the pathologic stage. That's really the way you get the full measurement of what the tumor is based on what its appearance is under the microscope. And also in terms of the technique that I mentioned, ensuring that we have either a stage 1 situation where lymph nodes are not involved. By the way, the surgeon would sample those lymph nodes. So it gives tremendous importance, information for the entire team to know the right treatment is being done. But really, for the most part, for a chance to cure a breast cancer, surgery is a very important part of the process.
Absolutely. And so measuring an MRI comes into play to find the exact placement of the tumor?
So MRI comes into play to help with the clinical information. The surgeon knows very, very well what we're likely dealing with. MRIs can also be quite important if there might be some question as to whether it's a surgical technique that could allow just the removal of the growth, or if we have a situation where it would be a more extensive surgery, basically mastectomy surgery, to provide for the highest chance of this being cured. MRI can give very good detail to the surgeon if there's any question about that.
And so, with stage 1, you might even have a mastectomy, or with stage 1, is it generally just surgery, maybe a check of a lymph node, and then that type of process?
Well, first part of that answer is understanding that mastectomy could be a very good treatment to have in anyone's situation based on a lot of the specific information. So it's one thing that applies across pretty much the entire spectrum of breast cancer treatments in particular is the fact that it's now a very individualized concept. We have targeted therapies based on the growth patterns of the cancer cells, and we have so many options available so a person can make that decision as to what really is in their best interest and what they feel is most appropriate for themselves. So, for example, a person could certainly elect to have a mastectomy surgery for a stage 1 situation. One of the benefits of doing that would be to state that you may not have to worry about anything like radiation treatments afterwards. And there's been another significant advance in the plastic surgery field in allowing outcomes to be much more appealing than what historically may have been the case several decades ago. So now we have so many options available to each person in terms of what makes most sense for them to do. So that's sort of a general statement about mastectomy surgery. But of course, we also have situations where if we for whatever reason, it would be difficult to just remove the growth from the breast tissue, then in that case, mastectomy surgery would be the alternative that you would have to be talking about.
So when you get to stage 2, are we still in a similar situation to stage 1, or has the situation changed a little bit where there might be some type of spread of the cancer?
So in general, the higher stages usually then would mean making sure that you have all the treatment fields available to have that very good chance of being cured. So as we start advancing in stage, it's basically 2 main factors: the size of the tumor and whether there's lymph nodes involved. We can unfortunately have a case where the size of the tumor may be such that it just would not be feasible to remove it from the breast tissue for all different situations or anatomical constraints, or making sure that we're having the highest chance of getting it cured. So the size dictates that situation. Lymph node involvement is part of the staging categories as well. Lymph node involvement doesn't really per se dictate mastectomy versus growth removal, but it has a tremendous impact on the subsequent decisions about what treatment should then proceed after the surgery has happened.
So that's very interesting. Is that the kind of analysis that just is a little bit more and more as you get to stage 3 and then stage 4?
Yes. For stage 3 situations, you pretty much are stating that we have the more advanced case that really should be incorporating the systemic therapies. Our medical oncology colleagues are the experts that you would be talking with about that. That ranges, even in stage 3, you may have a situation where it could be very minimal systemic therapy. Some of these oral agents that block estrogen production, for example, but usually you're talking about chemotherapy medicines combined with, as I mentioned earlier, these new frontier immunotherapies. So that's where that conversation would typically come into play.
So moving on to the different types of cancer, there's the estrogen, progesterone, and then the HER2 proteins. And you even see the ads for that, for medications for some of those on TV.
So that's been the mainstay of our algorithms for making those decisions about what additional therapies would be important after the surgery has happened. Estrogen and progesterone receptor proteins have now had decades of information and proof from what treatments could very much improve a person's outcome. There are now several medications developed which specifically would be designed to make sure there's very little estrogen circulating in the person's body after the tumor has been removed, if we have a situation where that would be helpful. So there's that knowledge has been around for quite a long time, and once again, there's been tremendous advances in having medications more and more effective in doing that. The HER2 protein is a bit more recent. It's proved to be incredibly important for us making our decisions. This is actually really the new frontier in terms of either monoclonal antibodies or treatments that are designed to positively affect the situation. So this is not going to be a more advanced aggressive cancer. The HER2 protein, it's actually what we might call a promoter. It's one of the genes that triggers a cell to grow in response to an important factor. A breast duct cell would need to be growing if in the lactating state, for example. So in the normal situation, it's part of that signaling which allows that to happen. But you can have a cancerous cell where it has an abnormally strong signal. That protein has been duplicated and is now contributing to the malignant property of that cancer cell. We now have these new frontier immunotherapies which can target that protein and nullify its negative effect on the process. And that has indeed led to increased cure rates for these situations where that protein is mutated in that cancer cell.
Very, very good information. Thank you for that. And so moving on to a little bit in terms of the treatment, which would include perhaps a combination of chemotherapy and radiation. Tell us a little bit about how those two types of treatments for people who have been diagnosed with breast cancer, stage 1 through 4, would be addressed. How is it chemotherapy first, then radiation? Radiation first and chemotherapy, or does it really matter?
Well, I would say it does. I would say it does matter, and the complexity of the treatment equals the complexity of the staging system that we now have.
Right.
The number one important thing that should be made aware is if the diagnosis has been made, you would want to make sure that you have your team in place. And that's what we pretty much all describe it as. You have a team, your surgeon, your medical oncologist, your radiation oncologist. You have so many other members of that team, which you'll eventually get to, your physical therapist, for example. But your team is so important in that initial process to make sure you've gathered all the information that we have learned, and then it can be so much easier to now be aware that this is the treatment that's best for me, and I need to go through with this. Again, it's so incredibly complex.
It is,
even for stage 1.
It's very, very complex. Yes, it's complex. It's one of the more complicated cancers, I believe, breast cancer, because of all the different types of proteins and the interaction and the location of the breast next to the lymph nodes.
and then that's the positive and the plus side and the minus side is the plus side is we've made so many great strides in cure rates and all across the board. It's not really a downside, but it's just complex. So it requires making sure that each person has had the full evaluation from all members, so it becomes easier for them to understand what's been recommended to them.
So tell us a little bit more about the radiology aspects of the breast cancer treatment, and it would be subsequent perhaps to the chemotherapy on a regular, mostly, or is it sometimes radiation is first? How do they make
so
it?
radiation is used for many situations and for several different purposes. I'd say most of the time radiation is sort of part of a treatment to make sure the area is fully sterilized after the surgery has been done. So probably the most common situation is when a growth small enough to be removed from the breast tissue has indeed happened. Very specifically, radiation would then be used to sterilize that breast tissue. And studies spanning several decades now have shown that the cure rates have without question been shown to be very much the same, whether mastectomy surgery was done or just the growth removed from the breast for these stage 1 situations. But the caveat that was learned, and it's really just a matter of the growth properties of a breast cancer cell starting in the milk duct system. You just can't be certain, based on microscope evaluation alone, that you do not have a few very tiny microscopic clusters of cancer cells remaining in one of the milk ducts after the growth has been removed. And what's been learned is using radiation to sterilize the milk duct system primarily has been the answer for having that same cure rate that mastectomy was giving previously. So that's probably the most common situation radiation is used for. But after mastectomy surgery, if it's a more advanced stage, same thing applies there too. You still, in many cases, can't be certain that you've got every last potential stray cancerous cell removed at mastectomy surgery. And there are several situations that we learn which can predict what the risk of that might be. But if it's a higher risk situation, radiation would then be used to sterilize basically the skin structures, the lymphatic channels and so forth, to improve the odds of getting that cured. So those are the two, probably the most common situations we would use radiation for.
That's excellent information. And just following up on the idea of the lymph nodes, lymphedema is one of the things that many people who have had maybe a large number of lymph nodes removed, or it's had some, maybe even with one lymph node removed, just as a matter of testing in certain breast cancer surgeries. So lymphedema is something that can cause the arm to get very large without the proper treatment subsequent to the surgeries. And I just wondered if you had some information for people who may be just recently having, surgery, or actually noticing maybe a change in the arm of the area where the breast cancer was.
Well, certainly, and this is such an important topic. As I kind of mentioned earlier, there have been great strides in all the fields of cancer management, and this is really where there have been so many strides in the surgical management identified. So going through history, most surgeries several decades ago, 60, 70 years ago, were very extensive. And it was just the current state of information of the world, basically thinking that very extensive surgery, including very extensive removal of the lymph nodes, had to be done to have a high chance of getting a cancer cured. And that experience showed quite directly that very extensive surgery under the arm can cause significant lymphedema. Lymphedema is a chronic, basically swelling of the arm, and the symptoms from that, the heaviness, the pain that can be associated, is just so debilitating. That experience is probably more than anything what has led to the evolution of surgical management. Understanding how much of a significant side effect that can be, the strides made regarding understanding what really needs to be done, how extensive a sampling of these lymph nodes have to be, has greatly led to the improvement in the overall quality of life results after our treatments. So now, again, in the stage 1 situation, you'd be hearing the term sentinel node dissection or sentinel node sampling, which is the technique that allows a surgeon to know really what important nodes to be sampled are and not have to do such an extensive removal of lymph nodes. And that has even now extended it to the stage 2, higher stage situations. Most recently, where even, as recently as maybe 5 or 10 years ago, the thinking might still be pretty extensive lymph node removal, whereas now we're learning in many situations we probably don't have to. The fewer nodes sampled, the lower the risk of this lymphedema. Still not zero, but it very much reduces that risk of that happening.
Of course,
So
I'm sorry.
Yeah. So that's fine. So women can be very much assured that there's been advances in understanding that to reduce that particular side effect.
And they have now occupational therapy and all types of, different types of things you can wear for sleeves to reduce any or stop any more, expansion of the arm subsequent to the surgery. So this has been fabulous, Dr. Hauser. We are down to our last minute. I can't thank you enough for doing this show with us. You are amazing. The great descriptions that you've given today, I think, will help so many people. And I will make sure that I get this podcast done on my website at the Capitol, but also it'll be here on WILI, and you can look it up right here on the website here. And we will all send it to you as well, Dr. Hauser. Thank you again so much for being on the show with us.
Well, thank you very much for inviting me. It was I can't believe this time went so quickly here. Thank you.
I know. Well, you did a fabulous job. Much appreciated. Have a good evening.
Yes, you too. Thanks.
Bye-bye. Join us next week for another great show. This is Susan Johnson, and we'll be joined again with Dennis O'Brien.